Patient care number 7. Still on, let's see, some patient injuries here. So stroke. I'm sure you've heard of the term FAST, face, arm, speech, time. They may have loss of motor control. There could be a speech impairment. Loss of consciousness is possible. Is there a facial droop? Is there an arm droop? Is their speech changing since you've met them? Then you need to get them help quickly. Cervical injuries, so if the patient is in a C-collar, you'll need to stabilize neck. The log roll with help, you're supposed to have 3 to 5 people. Who can remove a C-collar? Well, I'll give you a big hint. It's not us as RTs, right? So you shouldn't be taking any C-collars off. If there's a long bone fracture, how should you support the limb? Above and below the joint, being aware of where the fracture is, making sure, the distal end is not falling off the stretcher. You want to make sure everything is supported. Ask for help, communicate that help, and communicate to the patient what you need or what you're going to do. Types of paralysis, so terminology to kind of separate out here. Quadriplegic versus paraplegic versus hemi. Quadriplegic most often is involving all 4 of the limbs. Paraplegic, it's often just legs, possibly lower abdomen. And then hemi is one side. And usually the quadriplegic is a neck or upper back injury. And then para is below the neck and often a lower spine injury. Incident reports, they must be objective and as truthful as possible and be written as soon as possible. Documentation is key. So you're going to see documentation throughout a lot of the patient care information. Always document everything and follow the protocol. If you see anything as far as protocol in your answer options, following protocol is key. Fractures and pathologies. So basic review of fracture terms. Open versus closed, right? One breaks through the skin, one doesn't. Displaced versus non-displaced. One's going to stay in alignment and one's not. Green stick, this is going to be your fracture in children. It's that bending fracture. Spiral has the torsion look to it. And then comminuted, it's a break or splinter of the bone in more than 2 fragments. Let's see, more terms. Fractures and pathologies you should know. So what I want you to do is make sure you know what an avulsion fracture is. That's going to be that chip or piece that's pulled away from the bone. Subluxation is a partial dislocation. Boxer's fracture, I know you guys all know that one. It's when they've punched something, right? And it's that 5th metacarpal bone here. And the Jones is on the foot end, but it's also on the 5th. Let's see, Cole's fracture versus Smith. One is outward, one is inward. The Cole's is what you're going to see most commonly on elderly females. They're going to fall with that outstretched hand. I don't know if you've ever seen this abbreviation, but that foosh. And the Smith's is the reverse. The apple core appearance is colon cancer in the large intestine, so you would see that in a BE, or it has like, maybe it looks like a napkin ring is wrapped around, but that's what that looked like. The Paget's disease, or it might be referenced as osteitis deformans. The skull will have a cotton wool appearance, but often I see it as the pelvis picture here. See this sort of fuzzy, it looks like cotton wool in here. And then popliteal is behind the knee. Scheduling and sequencing of exams, just some general considerations you'd want to schedule in appropriate and timely fashion. So the sequence should ensure the patient comfort and fiscal responsibility. If they have co-pays for each exam, then we're not going to want to probably combine as many as we want in one day. The barium study should go last. Ideally, if the patient can handle it, you'll do several exams in the same day, but if they're ill or weak, you won't be able to do that. Your NPO patients should go early in the morning. Your geriatric and pediatric patients should also go early, and then your diabetic patients, because of their need for insulin, need to be aware of timing. If sedation is used for an exam, the patient must be given enough time to recover from the sedation afterwards. So if you're given a list of exams to say put in order, what should you do first? Well, you should do all the exams that don't require contrast media first. And then if there are lab studies that require iodine intake, then that would be next. Exams of the urinary tract, then biliary. Then if there are any CTs, the CTA would have to go next. A lower GI before an upper GI. Would a patient have all these in one day? Most likely not. But what they're looking for is for you to understand that non-contrast images should go first. So if you have a plain KUB or if you have an ultrasound, those would go first. Exams of urinary or biliary tract would then go next. A CT, if there's a CT in there, would go, and then a BE would be done before the upper GI. Let's see, basics on medical emergencies here. Allergic reaction, so latex reaction. Urticaria, hives, is considered minor. Then it's minor to severe. It could be severe, would be anaphylaxis. You want to check supplies, gloves, etc. Make sure you're asking about latex allergies on all of your timeouts. Cardiac or respiratory arrest. So CPR, you're going to follow the CPR procedures. It is CAB, compressions, airway breathing. Ideally, you have an ambu bag. And just go back to your CPR learning about the AED. Right? You're going to use that for sudden cardiac arrest. And remember, the AED will instruct you when to do the shocking. Make sure everyone's clear. What should you do first before doing any CPR? You should call for help, right? Survey the scene, call for help. Because if you don't call for help, there's no one there to help you or them. So make sure you go through all of those basic steps and don't forget those. Head injuries, try and immobilize until the cervical injury is ruled out. Wounds, if the dressings are bloody dressings, they're going to want to go in a contaminated disposal. Just some more common medical emergencies. So syncope, fainting, right? We went over that term already, but this is the most common one for RTs. Ideally, you put the patient Trendelenburg. You put the head lower than the heart so the heart's not working as hard. Okay. Hyperglycemia versus hypoglycemia. If you use cold and clammy, give them candy. Hyper would be too much sugar and they need insulin. Seizure, it could be small or large, but just try and prevent falling, prevent the patient from injuring themselves. Bleeding, it could be arterial or venous, but use direct pressure. Orthostatic hypertension is when happens from the patient going recumbent to upright. Epistaxis is the nosebleed. Vertigo is dizzy. Asthma, they might be having difficulty breathing. And then race and pass. So I know you all know this for fire. A rescue alarm, confine, extinguish, pull, aim, squeeze, and sweep. Just go back through those.